Good afternoon. This is Mohamed Othman, Assistant Professor of Medicine and Director of Advanced Endoscopy at Baylor College of Medicine. I'm here today to discuss my study titled A Prospective Study of the Risk of Bacteremia in Directed Cholangioscopic Examination of the Common Bile Duct. Before I talk about the study, I would like to talk a little bit about why we did this study. I'm an advanced endoscopist by training. A few years ago, I was planning to do an ERCP with cholangioscopy, and I asked one of my colleagues, do you give antibiotic for these cases? And his answer, he said, well, I don't know. Sometimes I do, sometimes I don't. So we tried to look up the literature, looked at the ASGE guidelines, and we did not find any specific guidelines that discuss the antibiotic prophylaxis in ERCP with cholangioscopy. We also looked at the literature, and we found there is no study that was designed per se to look at the risk of bacteremia in cholangioscopic examination of the bile duct. Why we think that ERCP with cholangioscopy is higher risk for infection? As we know, the single operator cholangioscopy is requiring water irrigation in order to distend the bile duct and in order to obtain a nice view of the bile duct. In the process of water irrigation of the common bile duct, you may cause bacterial translocation from the force of water pushing in the duct, and bacterial translocation can lead to bacteremia and infection after that. So our design of the study was very simple. We recruited 57 patients to the study. Our aim was to look at the frequency of bacteremia. It's almost like a pilot trial, because since nobody looked at that before. And we did a blood culture before the procedure, blood culture 5 minutes after we finished the procedure, blood cultures 30 minutes after we finished the procedure, and then we followed up the patient for 1 week after the procedure for symptoms, fever, chills, pancreatitis, and other symptoms, and we'll give them a phone call daily to look for that. Among the 57 patients included in our study, 24 were included for a structure examination, 22 were included for CBD clearance, confirmation of the clearance of common bile duct from a stone, 10 patients were recruited for laser lithotripsy. We did find that 5 out of 57 patients in our study developed bacteremia, which is an 8.8% rate of bacteremia, and 4 out of 57 did get cholangitis, which is around 7%. Interestingly, patients who had bacteremia, they most likely had biopsy of structure, and I would like to cautious about generalization of this finding. The study was designed to look for the frequency of bacteremia, but it was not designed to look for factor associated with bacteremia. Having said that, we did find that bacteremia was higher in patients who had biopsy of strictures. Cholangitis rate was also common in patients who did have bacteremia. So based on the finding of the study, we recommend now giving antibiotic prior to any ERCP with cholangioscopy. Of note, when we did the study, we did not give antibiotic. The reason is there was not enough evidence that we should give antibiotic prior to the procedure, and there is no ASGE guidelines recommending that. But of course now, after completing the study, we highly encourage giving antibiotic prophylaxis for ERCP with cholangioscopy. We are looking forward for the updated ASGE guidelines regarding antibiotic prophylaxis in endoscopic procedure, and we are hoping that ERCP with cholangioscopy will be one of the indications for antibiotic prophylaxis prior to ERCP. In the meantime, we are planning to conduct a future study examining the factors associated with increased risk of bacteremia in ERCP with cholangioscopy. I hope that you will enjoy reading our study. Thank you.